changes in the dermal pH, flattening of the relative ridges, loss of subcutaneous fat, and decreased dermal epithelial blood flow. These all are the features which can enhances the chances of ulcer formation over the skin. And do you guys hear me?
Yes, we can hear you.
Okay. The aging. Now we are going to discuss the extrinsic risk factors, like the pressure from the external surfaces, for example, bed chair, friction from being unable to move well, shear forces from involuntary movement, and the last one is the moisture, which is very important risk factor, like bowel or bladder incontinence, perspiration, and the wound drainage. So here, the National Pressure Ulcer Advisory Panel, pressure ulcer staging classification, they classify the ulcer into staging, stage 1, 2, 3, 4, and unstageable. So one by one, we are going to discuss these stages. In stage 1, there will be an intact skin. You can see from the picture, there will be no any breakage in the skin. The skin will be intact with non-blanchable redness of the localized area. Usually over the bony prominence, the area may be painful, firm, soft, warmer, or cooler than the adjacent tissues. Okay, in stage 2, we can see here the picture, there will be some damage in the superficial skin layer. So the partial thickness skin loss presenting as a shallow open ulcer with a red-pink wound bed without any slough. It may also present as an intact or open serum-filled blisters. It includes the tears, tape burns, maceration, or excoriation. Here is the stage 3, the full thickness skin loss. The superficial epidermis and the dermal layer, both are the loss. The fat may be visible. Here we can see the fat is visible, but the bone, tendon, muscle tissues are not. And maybe there will be a slough present. In the stage 4, it is a full thickness tissue loss with exposed bone, tendon, muscle, and slough or the scar may be present. Here we can see this is the blackish one is the scar formation, and the yellow one is the slough. And this stage is called unstageable when there is a full thickness tissue loss in which the base of the ulcer is covered by the slough or the scar. Until enough of the base is exposed, the true depth and stage cannot be determined. Here we can see the black one is the scar formation and the yellowish one is the slough. Suspected deep tissue injury, the purple or the maroon discolored intact skin or the blood-filled blisters due to damaged underlying soft tissue from pressure or shearing forces. The area may be painful, firm, mushy, boggy, warmer, or cooler than the surrounding tissue. Now there are two tools, or we can say scale, which are going to help in assess the risk and evaluation for the pressure ulcers. One is the Braden scale, second one is the push tool. So the Braden scale involvement of the six characters. One is sensory perception, second one is the moisture, third one is the physical activity, fourth one is the mobility, fifth one is the nutrition, and sixth one is the friction and shear. Every component have its own score, 1 to 4. There will be a more score, the lower the risk of ulcer formation. And the lower the score, higher the chances of ulcer formation. So this is a very nice table. The 6 features, sensory perception, whether the adult is having ability to respond to the pressure related discomfort. So the score 1, which is completely limited, unresponsive, they can't feel the sensation, so lower the score. And look at the number 4, there's no any impairment in the sensation. Patient can feel the sensation. So lower the score, the more will be the risk for the ulcer formation. Same in the moisture. The adult or the patient remain constantly in the moist areas, like due to perspiration or the incontinence, there will be high chances of ulcer formation. Look at the activity. In the score 1, the patient is in a bed fast, confined to the bed. Mobility in score 1, completely immobile, prolonged immobilization, bedridden. Look at the nutrition in score 1, very poor, never eat a complete meal, or the patient is NPO, or he is on or she is on the clear liquids or the intravenous for more than 5 days, and the friction or the shear. So this is a nice table by which we can assess the risk and evaluation of the patient ulcer. This is the push tool, which actually in which we can observe and measure the pressure ulcer. First, we can categorize the ulcer with respect to the surface areas. Second, we will look at the exudate. And third, we will look the tissue types. And then we will record the sub-score of each of these tissue characteristics. How much area is involved, how much it is exudate, whether it is none, light, moderate, heavy, and how much the tissue type, whether the tissue type ulcer is closed, or there is an epithelial ulcer involvement, or the granulation, or is it slough, and in the last, the eschar formation. So we will add the sub-scores and we will obtain the total scores. So the comparison of the total scores measured over the time provide an indication of the improvement or the deterioration in the pressure ulcer healing. Okay. So now a little bit we are going to focus on the prevention, how we can prevent the tissue ulcers, pressure ulcers. So our aim is to reduce the pressure and shearing effect, reduce the moisture, provide general skin care, provide appropriate nutrition, reduce the comorbidities, and involve the patient, family, and the caregivers. So in the prevention, we will perform daily skin inspection. Bathing and skin cleaning frequency is required. Moisturize the skin, avoid hot water or harsh solutions, and also assess and treat the incontinence. Either we can use topical barriers or absorbent padding whenever needed. And this one is very important. Proper repositioning frequently. Every 2 hours is required, repositioning every 2 hourly for those who are bedbound, every 1 hourly for those who in wheelchairs, and self repositioning every 50 minutes for those in wheelchairs. This prevention is very important. And avoid the manipulating the bony prominences. So practice proper positioning, transferring, and turning techniques is very important to avoid the friction and shearing forces. Always lift, don't shift. Use dry lubricant like cornstarch or protective covering to reduce the friction injuries. Or we can involve the rehabilitation program, physiotherapists to maintain or improve the mobility or the activity status. And also consider the nutritional supplementation support for who are nutritionally compromised persons. And in the last, we can say that the use adjunctive devices like air mattresses, limb paddling wherever necessary. Use pillow or padding to avoid any bony prominences such as knee from having direct contact. Elevate the head of the bed no more than 30 degrees unless the absolutely necessary. Also monitor and document the intervention in the outcomes, and having a fixed repositioning schedule like we discussed every 2 hourly, 1 hourly, or 15 minutes. So we have to document in the records. So here we can see that the pillows in between the knees, at the elbow, at the head, and the head should not be more than 30 degrees to prevent the shearing forces. People who can't move themselves, they need our help. These are the pictures of the air matrices which help in preventing the uh, ulcers, pressure ulcers. These are the foam, air, or the water mattress, or the special bed, elbow protector, heel protector, chair cushion. So this one is a heel protector, and this one is a you can say air mattresses. So the management. Before the management, we had to stage the ulcer and would like to order some investigations, including the wound swab and cultures. Usually showed mixed growth, aerobic, anaerobic, and normal flora. We will go for the blood, complete blood picture count, C-reactive protein, ESR, serum protein, albumin to assess the patient nutrition level, MRI and X-ray to rule out the osteomyelitis, ultrasound to check the Doppler ultrasound of the limbs to check the blood flow, venous flow. Is there any compromise over there which can cause the ulcer as well? And in the last tissue biopsy, because the prolonged skin ulcer can go to convert into squamous cell carcinoma, we called it marjolin ulcers. Here is the management according to the AAFP. So look at the wound or the ulcer, whether the ulcers are clean without any cellulitis, or the clean ulcer with cellulitis, or is there necrotic tissue. So the clean ulcer without cellulitis, stage 1, we will apply only protective dressing whenever needed. In stage 2, apply the moist dressing such as transparent film, cleans the wound. In stage 3, there will be a no necrotic tissue, or stage 4, no necrotic tissue. We will apply the moist absorbent dressing such as hydrogel, foam, or alginate and consider the surgical consultation whenever needed and clean the wound initially at each dressing stage. If there is a no improvement after 14 days, we can apply the antibiotic, topical antibiotic. If there's again no improvement, healing after 2 to 4 weeks of the apply of the topical antibiotic, we can go for the tissue culture, we can consider the osteomyelitis, and we can go for the systemic antibiotic. And same as in the clean ulcer with cellulitis, systemic antibiotic. And if there's a necrotic tissue, we will go for direct debridement. Sharp, if advancing the cellulitis or the sepsis is present or there's any autolytic, enzymatic, or mechanical if non-urgent, and then apply the dressing. These are the type of dressings and the indications like stage 1, 2, 3, 4, whenever transparent film, hydrogel, alginate, foam, hydrocolloid, and moistened gauze. So the management, first of all, clean the skin, remove the barrier, antibiotic wherever appropriate, and debride the necrotic tissue. Complications of the pressure ulcers are the sepsis, cellulitis, endocarditis, meningitis, because these are the foci from where the infection can travel to the heart, to the brain, to the meninges, fistula formation, osteomyelitis, inflammation or infection of the bony parenchyma, septic arthritis, sinus tracts, squamous cell carcinoma, as we discussed, the marginal ulcers, the prolonged skin ulcers can convert into squamous cell if we can't treat them. These called marginal ulcer, amyloidosis, drug-resistant bacteria, and in the last, maggot infestation, worm infestation occurs in that ulcers. So these are the complications developed in these cases. So the conclusion, evaluate the risk, prevention, which is very important, identify early, so these also should not go deep into the stage 4 or unstageable, and then manage it. Thank you so much.
Thank you, Dr. Avinash. That was a very excellent and great presentation. Dr. Nadir, do you have any input on that, please? Thank you.
Thank you so much.
Thank you so much, Dr. Avinash. That's great. I just want to highlight that it's an important topic, and as we get older or manage the older patients, I think we should think about that. Prevention is an important part, but if we have to deal with one of these ulcers, we need to know how to do the right way. So most of the time, the nursing staff or the nurses will know what to do. They have their own nursing, like wound nurse, specialized in that. but we need to know the basics so that we can instruct the nursing what to do. If it's complicated, if it's difficult to manage, then we need to go to the source or write a way to send to a wound clinic or a specialist like a surgeon to do the debridement and so forth. But thank you so much, Dr. Avinash. This is great.
Thank you so much, sir.
Thank you, Dr. Nadir. Now we will move on to our next presentation, which will be on the research bias. I would like Dr. Isra Ahmed to take over, please, whenever you're ready.
Yes, good afternoon, everybody. I will be presenting today bias in research. So can you see my screen?
Not yet.
Okay. What about now?
Yes.
Okay. Okay, so I am Isra Ahmed, and I'm glad today to present this important topic about bias in research. So starting by the definition, bias in research refers to systematic error or distortion introduced into study design, data collection, analysis, or interpretation that can lead to results that deviate systematically from the true state. And these errors can occur at any stage of the research process and may compromise the validity, reliability, and generalizability of the study finding. And this is our concern. There are many types of bias, and there is many classifications, but for today, I would like to go over the selection bias, observer bias, confirmation bias, recall, measurement, and publication bias. Okay, then starting with selection bias is defined as distortion in sample selection process. That occurs when the sample is not representative of the population, leading to skewed or inaccurate results. This can significantly affect the external validity of the study, and that to say will limit the applicability and generalizability of our findings. Here are some examples of selection bias. First of all, volunteer bias. For example, if you are doing a clinical trial about a new drug, and the participant volunteered due to their personal interest in the drug's potential benefits. They are aiming to get benefit from the drug. So you cannot generalize the result because other participants who are not involved and do not volunteer to participate, they were not included. Other example is non-response bias. For example, when conducting a survey on a specific health issue, where only those who have experienced the problem will respond. If we are studying some complication related to diabetes, only diabetic patient will be responding, and by that you are quantifying the prevalence of that specific attribute you are concerned about, and not studying it in the general population. And again, you cannot generalize your results. Another type of selection bias is the health worker bias, in which you will be studying your sample from the health workers who are currently employed, and this may not account for individuals who left due to health concerns related to work environment. Another selection bias is sampling bias. For example, when conducting a study on a smartphone, for example, you are concerned about the usage habit, but only you did your survey in a technology conference. So the general populations are not included. So putting in mind those examples, we should follow some strategies trying to mitigate selection bias. First of all, and most importantly, we should always do random sampling, especially when we are doing observational study, so that we can enhance the representativeness of the sample to the true population. On the other hand, if we are doing a randomized control trial, we should do proper randomization to the both arms of the study so that we can minimize the confounding and make that two arms are very much similar. Again, stratification, and should be done before the sampling. We should identify the stratification criteria so that we can ensure that every stratum is adequately represented and reducing the likelihood of bias. Other strategies is matching, and it's also important that we match the different arms of our study so that the groups can be comparable. And after all, we can do adjustment for the confounder. If we are suspecting potential confounders between the groups in the observational studies, we will try to adjust for that, and we can use the multivariate regression and the adjusted analysis when we are conducting our final representation of the result. Okay, then moving to the next type of bias, which is the measurement bias. It's defined as the inaccuracies in the measurement process. And by addressing this bias, we should do careful planning beforehand. We should standardize our procedure and commit to minimizing these potential sources of errors. And this type of bias usually affect the validity and the reliability, that would say the reproducibility of the study. So putting measurement bias in mind, the common sources of this bias will include instrumental bias, and that's if we, for example, use different plans for different brand of measurement instruments, we should expect that the readings will be inconsistent. Other thing, the observer bias, if different observers are using the same instrument, they can sometimes report different results. Recall bias, and this is mainly in the retrospective studies because there is a gap, there is a time lag between the exposure and reporting of the outcome. So we can expect some memory lapse. And the other aspect is social desirability bias. And in this, by this I mean that participants may provide responses that align with social expectation rather than their true experiences or behavior. Especially we encounter this type when we are doing surveys, and especially on sensitive topics like smoking habits, eating habits, and so on. So what are some of the strategies we can use to mitigate the measurement bias? That we should standardize our measurement protocol, and this goes with in the planning stage. We can do blinding, and this can be double-sided or triple-sided, even involving the statistician who will be doing the analysis. Calibration and training. Calibration for the instruments that we ensure that the instruments involved and used give the same measurement, and training of the observers so that they can read accurately the required measurements. The measurement on self should be objective rather than subjective. As I said, randomization, using multiple measures and then figuring out the mean or the common denominator will minimize the error. And to minimize the recall bias by limiting the time gap between the exposure and reported that desired outcome. Moving to our third type of bias, which is publication, and which the bias which is defined as the tendency to publish positive results more frequently than negative or inconclusive results. And by by addressing this type of bias, we should collaborate in this for the researchers, the publishers, and the policymakers. We should state a commitment to transparency, open access to data, and shift in the culture surrounding positive results can contribute to a more balanced and reliable scientific literature. And I'm going to elaborate on this in just a minute. Okay, so what is the impact of publication bias on scientific literature? It will lead to distorted representation of findings. By just reporting the positive or the statistically significant and ignoring the negative, then our data representation will be distorted. if we are, for example, we're studying a treatment, maybe we are, at that time we will be exaggerating the effect of that specific treatment modality. And this will unfortunately impair our evidence-based decision making because the data in the first place was distorted and misrepresented. Other impacts that research reproducibility concern, because if in the first place the data was not accurate, that means I cannot reproduce the same result by doing the same research again. And for sure, we will be wasting precious resources by doing so. So ways to address this and to mitigate the publication bias. Most importantly, we should do prospective registration of the study so that you will register your research beforehand and you will declare the methods you are going to use. If you encounter any negative result, you should publish that. By providing an open access to the data, we will enhance its transparency so that if any interested body can take a look into the data. The publication bias assessment in reviews, this is when we, the journals or the publishing bodies are about to publish these results, they should do assessment for this type of bias. And the journal should always endorse the commitment to transparency. The peer review process also help in this regard. And as I said in the beginning, we should collaborate between the researchers, the publishers, and the policymakers in this regard. And our final bias for today is confirmation bias, which is defined as tendency to favor information that confirm pre-existing beliefs. And that is to say that the observer or the researcher will only convey, and not only convey, will design, formulate his design and then interpret the data according to his own belief, and will report those data according to the tendencies of including only the positive results and downplaying the negative or inconclusive outcome. Again, how to solve this problem? With, as I said, registration of the studies so that the authority bodies can have oversight of the process. Blinded randomization will help to overcome this, the personal bias. To diverse your research team so that it's no more than one-man show. We collaborate different people in this process. Again, peer reviewing will help to mitigate this type of bias. Most importantly, we should always consider the alternative hypothesis, which is again is our null hypothesis or the desired outcome. We should always report our data with transparency. If we repeat our study, it will be the perfect thing to do because having the same result means that our research was successful, and to continue self-reflection and growth. So in summary, to minimize bias in research can be achieved by proper planning, emphasizing the importance of transparency and ethical consideration. And here, allow me to just say a few words about the ethical consideration in research. We must know that it is the ethical responsibility of the researcher to acknowledge and address a bias because you are doing most of the work. It's of utmost importance that to transparently report and pre-register ongoing studies. And by doing that, we can ensure that our research is accurate, and that is, say, reproducible. We will be guarded against selective reporting, and we will enhance the public accountability of our research. And I found this interesting by mitigating the hierarchy, which is hypothesizing after results are known. And this is which is known as post hoc analysis. After you obtain the result, you go back and set your objectives. You will minimize the questionable research practices about misconduct in research, and you will gain the trust of the population and the authorizing bodies. You are building a foundation for the meta-analysis because, as I said, we don't want to compromise our evidence-based pool of information because this is mainly depend on meta-analysis, and meta-analysis depends on accurate research. And overall, by doing that, we will be accounted to the credibility of the science. That's concluded my talk for today. If there is any questions. If no, I would like to thank you, and sure, I would like to listen to Dr. Nader because he is the expert, our expert in this regard. Thank you.
Thank you again, Dr. Isra. This great presentation, to the point and straightforward. So I think I agree with you. It's an important topic, and it's everyone in the research area supposed to know how to figure out from the start if there are any bias expected, and when they do the research, if there is any bias that was found, they have to raise or minimize or address in their report. So before you submit your manuscript, you should raise the point that we found this, or we expected this, and we found this as far as a bias concerned. So thank you so much. This is important topic.
You're welcome. It's my pleasure.
Thank you, Dr. Nader, and thank you, Dr. Isra, for a wonderful presentation. Now, I would like to present on topic about making a graph using Canva. So I'm going to share my screen. So while I'm sharing my screen, I want to mention a few things about Canva before, like we about are you guys able to see my screen? Can you hear me?
Yes, we can see.
Yes.
Thank you.
Yes.
And the Canva page. Right here.
But I think your voice is not clear well.
Sorry about that. Let me retry again. Can you hear me now? Okay.
Yes, now we can hear you.
Okay. Okay. I think there is some problem when I'm sharing my screen. Let me try one more time. Are you able to hear me now?
Yes.
So basically, when we are doing our, when we do research, or when we are making any sort of a presentation, or when we are adding some graphs, charts, business, a lot of apps we can use, many Google Drive, Slide, or graphics, or or a website like Canva offers variation of templates and all other things you can add to your presentation. So I'm right now on this web page, and I'm going to add you can first of all is you need to log in. You can log in simply by using if you're using Apple, you can use that using in order to log in. Once you're in, can come page. I'm gonna click on Design Spotlight here on the tab on the left side, and here it says Graph and Charts. As you can see, Canva of other modes for Visual Suites to create presentations, whiteboards, PDF creators. They have video editors. They have also other social media editors where you can edit your YouTube video, photo editors, even print a business page, resource, etc. So I'm gonna go down to Graph and Charts, and go down. So here, as you can see, I can start with adding a document title and create my graph here, or I can go down also and I will have another area. And first of all, why Canva? Why we want to use that? Because they give more than 20 professional types of graphs to choose from. They are professionally designed templates to fast track your workflow, very easy to edit, very easy to implement. They give more visualization of given data. So there is no hard software, or there is no hard learning curve here. I just log into this morning, and I was using it very first time, and like literally within 10-15 minutes, I was able to create the graph very easy. Once you create it, you can publish, share, or download your high resolution graph to anything. You can also embed your graph in your presentation if you're working in PowerPoint or Google. Then it's very easy to drag and drop the tools to for the people like us who doesn't have much of experience in design. Again, how it works, once you can create a graph in 5 very easy steps. Select graph or diagram template, add your data or information, icons, illustrations from the given library, change color, fonts, backgrounds, and then you can just simply download, print, or share. And I'm gonna go down a little bit. Same thing. Okay, so they have various types of graphs, and if you cannot decide, they can help you to decide what kind of graph to use. There are area charts, there are bar graphs, there are comparison charts, donut charts, pie charts, T charts, and diagrams. Several tabs.
It seems you are muted, Mihir, or your voice is not here. Mihir?
Yes, now we can hear. Dr. Mir, we can't hear you.
We can't hear you. We can't hear you. Hey, Mihir? Mihir? So I think his mic is disconnected. So just to recap, can you hear us, Mihir? Can you hear us? So while he's fixing his mic and audio, so basically it's a useful tool that we can use, and I think every one of us can try it and see, so that in the future, if you need to make any type of graphs, this is a very useful one. There are others that you can use, but this has plenty of options, colors, and you can make fancy graphs. So thank you so much, Mihir. Now, you want to give us your feedback? I know you mentioned you used it extensively. Go ahead.
Hi everyone. Can you hear me clearly?
Yes.
Yeah. Hi everyone. I know Dr. Mihir was trying hard to explain how to work with Canva, but unfortunately the connection was bad. The first time I was introduced to Canva was before maybe 7 or 8 months. I was asked to present on how to present Canva as a graphics and other integrated tool of vision and design. So the one thing I learned about Canva was, even though there's a lot of YouTube videos and instrumental tools to introduce you to Canva, the best way I learned about Canva was by try and error. So the first time what I did was I introduced to the group what Canva was. It was a free graphics tool. The subscription was for free. And I think recently, before 3 or 4 months, they have updated about their privacy policy and their usage of Canva as a graphics tool. So the one thing I learned was way better than PowerPoint, because they do have already a prepared design and prepared categories such as graphs, posters, conference presentation, web design, and different formats of layout for any professional presenter. So that was the biggest advantage one. And secondly, it was exclusively made for that purpose. So PowerPoint have probably 20 or 30% of its features featured on graphics, but Canva was exclusively designed for that. And the third thing I learned about Canva was while using Canva, the only way you can learn about Canva is you have to play around. So I even used Canva for design of the blood pressure app and immunization app for the introduction feature. So they will give you different features such as graph, picture. You can also buy features from Canva if you have an exclusive membership or if you have a subscription of about 12 or maybe $18 a month. So the best way you can learn about Canva is just once, like maybe for 1 hour or 2 hours, you have to play around with it. I even used Canva for my poster presentation for the 51st NAPGAR meeting. The feature was really interesting and you can design whatever you want. And it also gives you a feature of printing out in any dimension and the format you want. So the summary is just, even though there is a tutorial on how to use Canva, the best way you can use Canva is just click every button you found in the future. With time, you'll master it. You know it, how to share it, how to download it, and what version of file also you can use it from Canva as a feature. And it also have a feature of inviting team members, maybe 5, 7, or 10, so that all of you can work on the same project with the same access through Gmail or any form of email. So that's why I wanted to share with the group. So it's a very good tool, especially for people who have interest in research, web design, presentation, conference, and poster. Thank you.
Thank you so much, Dr. Nawat. This is also very helpful. So I encourage all the fellows to try it. Maybe start with just any data. You can create your own basic data, so you can make up some data. Let's say how many fellows in this group, male, female, who's married, who has kids, and you can just come up with some numbers and then create the graph and see how it works. So this is how you can learn. And when you know how to do it in the future, when we have posters or if we want to create graphs or papers, at least we know what tool we can use and how to use it. Thank you so much, Dr. Nawat. So I don't see Mihir back.
Dr. Nadir, Dr. Mir is having trouble with his computer and he's trying to join.
Yeah.
I don't know how much time he will take.
Sure, yes. So I think we got the main idea, but I think he also has some presentation that he wants to share later. So we will discuss about that. But the tool, the Canva, is very useful. And we use it for one of the posters that the Alzheimer Association meeting that was a few months ago. Some of the group created the poster. They created the video for that poster. So they sent their small couple of minutes videos to me. So I used Canva so that I can create the whole video for 4 or 5 minutes to go along with the poster presentation. So this is one option also to use it for video editing. Thank you so much.
Dr. Nadir, was it the one that we presented?
Yes,
Oh.
this Dr. Ham. This is how I got your video and edited the other videos so that it can be in one video.
Yes.
And to the point, yes.
All right, thank you.
You're welcome. Thank you so much. All right. We can go ahead with the next topic if there is any topic in the list. So we can start discussing the updates. If there is anyone who has any updates as far as the projects, questions, concerns, and suggestions, please go ahead. Go ahead, Dr. Noor. Yes.
Mine is not a suggestion or an update, but I was wondering because I was checking the project we work on, the pressure care and wax aware. And even though there was a lot of effort and hard work done, the number of downloads on that project is still low. So for those of you who have still the link to that application, it would be nice if you download it on your cell phone so that the number of downloads will be high and the exposure will be high. And I'm also thinking of exposing the project effort on a big platform. So before I post it, would be nice like if you guys download it, because a lot of effort has been done and the number of downloads is only probably 10 or 15 I see. So it would be nice if we expose what we have done the last maybe 3 or 4 months, like on a large scale basis. So it's a little bit of suggestion for those of you who are involved in that project. It would be nice if you download it on your cell phone so that the number of downloads will be high. For those of you who are not involved in that project, when we officially post it, it would be nice if you also download it. So this is my last message. Thank you.
Excellent. Thank you so much, Dr. Noor, for sharing. So if you have the link for the app, you can share it in the chat or maybe in the WhatsApp group. So each team and team leader can discuss how to increase the number of downloads. So one thing we can do is every one of us here, we have about 53 people. So if every one of these 50 download the app and encourage their friends and connections with in the medical field, maybe 5 or 3, we'll get into more than 100, 150 easily. So that doesn't include the other fellows who are not attending today's meeting. But thank you, Dr. Noor. So Mihir, welcome back.
I'm so sorry, Dr.
No,
Nadir.
that's
Some
okay.
reason my whole system crashed and I just didn't realize.
That's all right. I had my computer as well. So the other one I had the laptop. So
Yes.
things happen.
Thank
But thank you so much for your presentation. This is a useful tool, and we discussed how we can use it, not use it, and I used it for video. So we can move on to the next agenda topic.
Sure. Next agenda is some reason I'm not able to use the app also. It says service unavailable, but we had one topic and nobody could select for that. So it was on PRISM trial. So
we can book it for next week or in the future. No
absolutely. So I think from our side that is it. And
you sent email. So you want to discuss
Oh,
or
yes.
share your experience? Yes.
Yes, actually, I have to connect it. I'm sorry. I need a couple of minutes to join. I mean,
So in the meantime, while I'm here, he presented in one of the conferences, so he will share his experience with how it went. So I know in the past also know presented in San Francisco, and other teams presented in other conferences as well. So anyone wants to share their input. There are different ways of presenting your work in these conferences. One of them is actually in person. This is what Dr. Note did a few days ago. There is another way to do it virtually, so you can create your poster and send it, and then people will look at it, read it. The options include a video along with the poster. This is what the Dr. Reham and our team presented at the Alzheimer's Association. So they have the poster and they have the video alongside with that. So Dr. Naut, you want to give some feedback?
Yeah, even though I explained before maybe a week, so there are two ways of going on how to present it. One is for the average medical professional who attend the meeting. So for the average professional who attend the meeting, most of them, they don't want to know about the details of what you have done. They just want a 3 or 4 minute summary of what's your paper about, why you decided to do research on that, and how you come up with the idea of doing the research and what were the results. But the other aspect of people are technical people who really know about the details of how to do research or know the details of about the disease pattern or the topic itself. So if you feel that the question that is directed at you is from people who have an expertise idea of on what you have done or on what you are doing, this is where the time you are required to give an extensive explanation of your findings, why you want to do the research, and what was the conclusion and takeaway message. So this was on the paper aspect. And the other aspect is how to make the paper, as I was explaining it earlier. The best way you can do a poster is on Canva because they do have features and you can do it maybe in a week or 2 weeks. And the third aspect of the presentation is just because at the end of the day, especially if you end up presenting in person, you have to take advantage of that situation. So it's better if you connect with a lot of people, regardless whether they are medical students, residents, fellows, first-time attendee, project manager, or committee selection for new recruitment for research fellow. It doesn't matter. Usually, at the end of the day, out of 100 people, 5 or 4 very lucrative connections may show up. So try to sell yourself at the same time. Try to sell your institution. And the one thing I wish I have done was, I wish I had 1 or 2 people. I even said it last week. I wish I had maybe 1 or 2 people from the same fellowship, so that we could have 2 or 3 posters from the same fellowship, and you feel comfortable. You will connect. You will have time for coffee, and people will look at you as an institution rather than as an individual coming from a single university. So for those people who are working on abstract or research or whatever line of research, try to connect with other people who have a plan or idea of presenting as a poster, so that it's better if you present it to one conference. And lastly, if you end up being the only person presenting from one institution, 1 week or 2 weeks ahead, try to tell your ideas or try to tell people that you will be attending that conference. You might never know that people from your LinkedIn account may show up at that conference. It will be a boost on how to do things. And also it will have this home feel factor when you go there. So that's my only advice to other people.
Thank you so much, Dr. Naut. So yeah, when I did my first poster a few years, like a long time ago, I agree with you. So you make connection, and the beauty about in-person presentation, so people will ask you, but you will have free time. So you will go around and see how other posters are presented. So if you have questions, you can ask questions and see other people answer the question. Or if you see how the judge will ask questions and how the person presenter presenting the poster will answer these questions. The other beauty about it is that you can also create connections. So let's say some of the people who are higher in positions, when they come along and ask you specifically a specific question about the topic, you can ask about their background. So one thing is to say, so which institution you are from, and then can I get your card so we can see if you can collaborate. So this is how you can start collaboration and working with higher position people, professors or something like that. So it's easier to collaborate and create some new projects. Thank you. Sorry about that. My computer also went down. So any other updates? Actually, Mihir, maybe you can go ahead.
Hello, can you hear me? Hello, Dr. Nadir, can you hear me? Hello?
Yes, we can hear you.
Okay, thank you. Thank you. Let me share my screen. So a couple of weeks ago, we had our Physical Therapy Association's Michigan chapter fall conference, and I presented with one of my friend on the topic. We presented on a case report for elderly female with BPPV and patients with Parkinson. So let me share my screen. Let me see. Can you all see the presentation?
Yes, we can.
Okay. So let me. I'm so sorry. Looks like today is not my day today. So we presented on case report is effectiveness of canalith repositioning maneuver in treating posterior canal BPPV in an elderly patients with Parkinson disease. It was a case report, and so we kind of went through the introduction of dizziness, which is a frequent complaint of patients with Parkinson, and orthostatic hypotension is most of the time that could be the cause. Vestibular vertigo usually accounts for almost like quarter of dizziness complaint, and it has 12 months prevalence of 5% and annual incidence of 1.4%. The prevalence rise with age and about 2 to 3 times higher in women than in male in older aging population. Vestibular symptoms and dizziness are usual and significant problem in elderly patients where their prevalence has been estimated to be 30% in persons older than 60 years and approaching 50% after the age of 85 years. The objective was to assess the effectiveness of modified canalith repositioning maneuver in treating patients with posterior canal BPPV, who patients with the Parkinson disease. This study also aimed to identify the changes in pre and post values of dizziness handicap inventory and dynamic gait index scores following the canalith repositioning maneuver. So the case description was 67 years old female with history of Parkinson and deep brain stimulator who was referred to physical therapy with diagnosis of dizziness. She reported complaints of severe spinning dizziness with positional changes like getting in and out of bed and or rolling in the bed. She also felt unsteady while standing and denied any complaints of syncope, lightheadedness, diplopia, loss of hearing, or earache. She denied any history of falls in past 1 year. Since patient was already being treated in our clinic for Parkinson, we did not assess her for any balance impairment at this time. She also denied any complaints of migraine, photosensitivity, or phonosensitivity. Vertebral artery screening was negative bilaterally. The modified Dixie-Hallpike testing for right posterior semicircular canal was positive for upbeat rotary torsional nystagmus, which lasted for 15 to 30 seconds with subjective complaints of spinning sensation. She scored a rate of her perceived vertigo 9 out of 10, which was very severe. The sideline roll test for horizontal semicircular canal was negative bilaterally. Dizziness handicap inventory score was 30 out of 100, and dynamic gait index score was 19 out of 24, which describe or indicates as a moderate fall risk. Now, this was the modified Dixie-Hallpike testing for right posterior canal. As you can see in position 1, the high sitting with head turned 45 degree to the right And second position, this is the modified Dixie-Hallpike test for right posterior canal. As you can see, the body laid back with head turned 45 degrees to the right, and there is a cervical extension of 20 degrees. As you can see in the last picture on the right, there is a 20 degree of extension of head or the cervical with 45 degree of rotation to the right. Then modified canal repositioning we have done for the right posterior canal. We turn the head 90 degrees to the left in position 3. And from there, we roll the body from supine, means on the back, to the left, with keeping that rotation of the head at the same time by supporting the head. And then in the position 4, adding a liberatory head shake to move the debris from the urticaria so into the canal, so that could reduce the dizziness effect. Then slowly the body was brought to be seated with head tipped anteriorly or flexed anteriorly in the last position 5. So the nystagmus of posterior canal BPPV, I'm trying to open the YouTube video here. Probably you guys can see the upbeat rotary nystagmus. So now it's in the slow motion. Okay. So post-procedural precautions 48 hours was not to bend over, not to lay on the right side, and sleep with head and elevated. Outcome was she was successfully treated with a modified canalith repositioning maneuver and was seen frequency of once a week for a total of 4 times at the outpatient clinic. And modified Dixie-Hallpike test for right PC was noted to be negative at the end of the 4th session, with no subjective complaint of spinning and no observable nystagmus. The dizziness handicap inventory score was improved to 0 out of 100, and the DGI, the dynamic gait index score, it was improved to 22 out of 24, which indicated minimal to no fall risk, and rate of perceived vertigo score dropped to 0 out of 10. So we have shown some results in a graph. So as you can see, dizziness DHI score dropped significantly after the visit 4, and same with the rate of perceived vertigo. Also, DGI was improved. So fundamental pathophysiological process in BPPV involves dislodged autoconia. Sorry. Yeah, I clicked. Let me go back. Okay. All right, I'll just go this way. So fundamental pathophysiological process in BPPV involves dislodged autoconia from the macula of auricular otolith that enters the semicircular canals. BPPV usually arises from the posterior semicircular canal, which is the most gravity-dependent canal. posterior canal BPPV is the most common type of BPPV, which occurs with the rate of 85% to 95% of all cases. Recent finding has suggested that untreated BPPV in older adults could increase the likelihood of falls due to reduced sense of equilibrium. Prospective studies show that between 45% and 68% of people with PD will fall each year, with a large proportion of 50 to 86% falling recurrently. The Parkinson's Foundation reported that BPPV may occur in 11% of people with PD who experience dizziness and becomes more common with age. This study highlights the importance of canal testing while treating elderly patients with Parkinson's who present with chief complaint of dizziness. However, limited studies have correlated occurrence of BPPV in Parkinson's disease. The intent of study is to consider canal testing and canal repositioning in PT practice while treating patients with Parkinson who may have dizziness secondary to BPPV. So that is it, and this was the also we attach also the virtual poster to that. Thank you. And any questions?
Thank you so much, Dr. Mihir.
Thank you. Thank you for letting me to present on that. So that was a unique experience I had. It was not actually a poster presentation. What they called was a platform presentation. So we were allowed 15 minutes of slot to present. We were like 4 different presenters who were in the same hall for an hour to present. So we had that they had almost 40 other poster presentations, but ours was more on platform presentation. So we did a presentation using slides. So it was good experience. Thank you.
Excellent. Thank you. Yeah, this is also a different form of format of presenting. Sometimes we call oral presentation. They will invite you to do maybe 20 minutes, something like that, present your project from A to Z. Sometimes they present it as the winners. So they will select the first or second winners of the posters, and then they ask them to present orally. So great work. Thank you so much for sharing. Any
Thank
questions
you,
for here? If not, we can go ahead with next last agenda item. And so any updates, any questions? So we have new fellows. Usually we accept the new fellows in end of March, April, but some joined lately. So we created 3 more teams, and each team will have 1 or 2 leaders. So if you are new fellow in this program, please expect an email from your team leader. So you will be connected, and most likely you're going to use WhatsApp group or any type of communication. We can use email, text, phones, or WhatsApp group or other Telegram, for example. It's just a way of communication so that you can connect with the leader if you have trouble, if you want to present, if you want to participate, and so forth. So thank you all the leaders for moving forward with this program and encouraging your team members. Thank you all. And no worries, technical difficulties happen. It happened to me as well. So I have my computer, it's very slow. I used the laptop, it went dead, I didn't charge it. So things happen, so no worries.
Thank you, Dr. Nadir.
Yeah. Anyone with new ideas as far as new research ideas, research questions that we can work on? I know some started working on converting some of our previous posters that were presented in conferences into a manuscript. So this is an easier way of making more publications. So you take whatever poster that was presented, because it's a summary of a work, and you can enlarge or increase or elaborate on that work. So what you can do is you can look at one of the posters, create a team, and then see if we can work on the expanding a little bit more with references as far as introduction, and maybe we can redo the method part, so that if we did the project in 2020, for example, now 2023, 3 years, there must be something happen. So if we can collect more information recently, that will augment or will support our paper, and also see if you can get the results presented in different formats, tables, graphs, and so forth. So the team can help you with that. And then the last part will be the conclusion and the directions, future directions. So you can elaborate on that also more freely. You can target different journals, and according to what the topic is. Curious is one journal, but we can target others. So we can collaborate with other members out of the institution here in Michigan. We can see if we can reach out for collaboration with other institutions as well. So this is some ways we can build on what already previous fellows did in the past. So, Mafaz, go ahead.
Hello, everyone. Hope you guys have a good day, and thank you for the presentations. I had an idea which I was thinking about for the couple months now, about 2 months. I wanted to study the effects of vaping on adolescents and adults, because I keep on seeing patients and then I'm not able to give them an honest answer if it's actually bad for their health, or is it still under studies. So I wanted to ask if this is a possible area that we can work on.
I think it's a great idea, and the data, I'm not sure how much we can get, because it's recent stuff going on, and most likely you will find some supported by the industry. So I think it's good field to investigate or research. So we can come up with a certain question, and then we can do either literature review, or we can do any method of research to answer that question. So
yes.
Yes.
Thank you very much, Nadir. Yeah.
You're welcome. Good idea. Any other research ideas? Any questions, suggestions? I know it's time for the interviews and the application process. People are busy arranging this, and so I just want to encourage everyone to do your best, and we are here to help. Let us know how things are going. So if no more questions, I'd like to thank you, Mihir, and your team. I'd like to thank all the presenters, all the attendees from today's meeting, and the future who will watch the recording. Thank you in advance. Thank you, everyone, and we'll see you next week. Have a wonderful day, night.
Thank you, Dr.
Thank you. Thank you so much.
Yeah. I also thank the presenters today.
Thank you, Dr. Nader, very
No,
much.
no.
Thank you, Dr.
everyone.
Nader. Thank you
Thank
so
you.
much, Dr. Nader. Thank you, everyone.
Thank you.
Assalamu alaikum.
Yeah, alaikum.
So much.
Thank you so much, Avinash.
Bye. Have a wonderful day.
You too. Thank you.
Thank you.
Anytime. Thank you. Assalamu alaikum. Dr. Amal, if you're still there.
Hi, Dr. Nader. How are you?
Assalamu alaikum. Very good. How are you?
I'm fine. Thank you so much.
Excellent. Any updates? Anything new?
So we are working on the cancer screening app, and Dr. Rayan and I are working on the technical part of it. We already completed the data collection, and we have all the up-to-date information. So I'm now waiting for Dr. Rayan to send me the the code and the design for the homepage, and then I will complete my task. Like we shared the technical task together. She's an expert also in this.
Excellent. Sounds good. So I want to ask you a favor. I'm trying to figure out how we can build the previous apps into Apple iOS format. So I don't think it's a terrible, difficult task, but we'll see how it goes. So my question for you, when you build the first app, do you have the basic information in like a text format or let's say, yeah.
So yes, it was in text format, and I asked my team members to arrange all the information in a Google document or Excel sheet, so it's easy for me to just copy paste.
Excellent. So if this is my question, if it's in these two formats, that would be easier when we build a new version of the app for Apple, is to just copy paste the text there. So
So I
do you
have
mind
like
you share
yeah, sorry. So
if you can share with me the links, that would be great. For one app, we will start with that, and then we will move on.
You
when
mean
you have everything.
the link for the documents or?
Yeah, the documents, the basics.
Okay, okay. Of course. So I have read about this process of making an application in the App Store or for the App Store. So what I know is that I should be familiar with a programming language, like it's called, I think, Swift. Even if I'm not
Sorry
sure.
to interrupt you.
No, it's okay.
I started working on Swift, so this is what I was trying to say. I know the basics of the coding, so I learned some of the Swift. So my task on what I wanted to play around is to build something from scratch and see how it works. But for me to build that into the app that you already have, I need some of the raw data so that in the future I can just copy paste and see if we can get that running. So yeah, a Swift program is kind of challenging for someone who doesn't know the coding part or the behind the scene kind of things. But we
Yeah,
can
it's not
try.
visual.
I'm gonna try to work on it. So I have the Apple Mac with me, and I downloaded the Xcode and I watched some of the videos, so that I'm gonna try to build some basic app and see if it's working fine. Then we can incorporate and try to match your previous app and then work it from there. So you don't have to worry about the learning process of the coding.
Actually, I always wanted to learn that, but I couldn't find the time for this. But it's a future plan. Of course, I want to learn both Kotlin and Swift, so I can do, even in Android, I want to do something like professional, not like I want to skip the step of building in MIT and Codular. I want just something like programming, actual programming. Yeah.
Yeah.
So
Sounds good. It's interesting.
So yeah, this
but
is interesting actually.
yeah, I'm trying to build it using AI. So I watched some of the videos that you can create whatever you want using the AI. So if you're stuck in one place, you just go to AI and then say, hey, I want this, how to do it. Then the Swift will give you an error. Then you go back to AI and tell, hey, this is the error. So they can fix it. So it's fun to do. But as you said, it takes some time. So yeah.
Yeah. So yeah, of course, I will collect all the documents and send them to you. And it would be a great step, actually. Thank you so much for that.
Oh, you're welcome. Thank you. Anything else you want to share?
Thank you so much.
Thank you. I appreciate it. Have a wonderful day. Assalamu alaikum.
Alaikum salam.